Annemarie, thank you so much for joining me. I've been really looking forward to speaking with you.
Thank you. It's a pleasure to be here.
I mean, I know your research isn't directly focused on multiple chemical sensitivity, but there's so much in your research that is relevant, I think, to folks with the illness. And I wanted to start off by asking you about what you describe as the transformative nature of the diagnostic moment. The
Yeah.
ability of the diagnosis to convey identity is powerful. For example, you write that patients who have diabetes or bipolar, they use those terms. I am diabetic. I am bipolar. What is the transformative nature of the diagnosis?
One of the things about the power of diagnosis, and why is diagnosis so powerful? It's because medicine is so powerful. And why is medicine so powerful? It's one of the professions, it self-regulates. It is the profession which differentiates between normality and what isn't normal, right? It's the one that says you're okay and you're not okay. That's power, isn't it? And it actually, by giving you a diagnosis, it says you're okay, but you're sick. So that's why medicine is so powerful. It can tell the world's whether you need to come to work or not, right? That's power. In my book called Putting a Name to It, Diagnosis in Contemporary Society, I talk about the diagnosis of compassion fatigue. And actually, my research found the first mention of compassion fatigue as a disease in a Portuguese nursing journal in the early 1990s. And it was talking about ICU nurses. I was one of those. What it didn't talk about, it decided to talk about it in diagnostic terms rather than, say, labor and management terms. And of course, we get overwhelmed when we have 3 dying patients, not enough support, no one to talk to after they all die, and you feel like it might have been too much work, burns your brain out. Should we be calling that compassion fatigue, or should we be calling it management failure? The diagnosis has more power than management failure. So let's look at multiple chemical sensitivities for a while. I know that everyone listening to this either feels very unwell or is close to someone who feels very unwell, and that's bad. We're talking about pollution. We are. We have to have diagnoses in order to make an impact on corporate legislation, regulation. But what we're using diagnosis for is both to feel better, but politically activate to say, hey, there is something bad going on here. There's something that needs rectification.
I want to turn
Yep.
back to the notion of classification. People with MCS, when we present to the doctor and we have multiple systems impacted by reacting to chemicals, the response is the doctor's overwhelmed, too
Yeah.
busy, doesn't have enough
Yeah.
time.
Now, may I put on a different hat? I'm also a nurse. I'm a nurse, and I'm very interested in how we tell stories of diagnosis. Now, one of the real challenging things, but it's a really powerful moment, is this moment where you tell your story and you go to the doctor and you say, this is what's wrong. And thinking about how you tell the story effectively and quickly. We recently, I hope my husband doesn't mind, but he'll forgive me perhaps if I do tell the story of his long COVID. And he had to go see the doctor on a Saturday, which means he's going to see a doctor he doesn't know. So what is the point that I'm going to highlight when I go in there so that I can get the kind of attention which I want? Is it about this upper respiratory thing? Is it about the fact that I have long COVID? Is it the fact that our son had pneumonia earlier in the month? What is the story that I need to bring into this doctor so that they will pay attention to what's actually going on with me? And some of the things that one might consider is focusing on how these stories are told effectively in such a way as to deliver the important information without sounding frantic, because there's so much to talk about. For example, one might be practiced at saying, I have an atypical multiple chemical sensitivity, which is typified by X, stopping there. I am worried about Y today. We have 2 extremes when we're talking with a doctor. One is the sort of flustered, I need to say everything so that they don't miss anything. And we know that's got some advantages and some disadvantages. And the other thing that we have is this expectation, and I would doubt that the members of your community quite have this expectation, but many people go to the doctor and say, "Doctor, I don't feel well,"
Hmm.
and expect some sort of omniscience that will allow the
Hmm.
doctor to see. Getting the story right and crafting them and working on them and sharing them so that when you
Yeah.
go to the doctor, they are not overwhelmed. You've made your point clearly, and you've made the right point clearly.
One of the challenges, and I was recently with a new medical provider, and I told them my history, and I just felt a judgment. There was a clear
Mm,
before and after moment. I could tell by the way they were treating me, I was being judged. And I wonder if this is something we often experience: judgment, dismissal, misdiagnosis. Because you write, a diagnosis must not only be visible, but also agreed on. And if I'm not mistaken, you write that HIV/AIDS, there was a long period when it wasn't agreed on by medical
mm,
professionals. And then there was a point of consensus. And you could
mhm.
probably say the same with conditions like dyslexia and maybe long COVID, but maybe not yet, and
Yes,
Lyme disease.
yes,
So right now with
yes.
MCS, we're at a stage where there's no consensus in the medical community. So that's when we're met with bewilderment, judgment, and shrugged off and told it's in our heads. Is that how you see it?
Yeah. Yes and no. It will help, but there will still be this shrug thing. I wrote a paper recently for Endeavor. It's a sociology journal where we talked about how medicine deals with the things it can't fix. And I think that's an uncomfortable moment. How do individual practitioners and the institution itself deal with this discomfort? Not very well. Can I come back to your experience with your new clinician? Often when we start, we can see the moment where we lost them. Did you see that happen?
Yep,
Was
I
it at the
felt it.
mention of the condition, or was it as you started to provide more information?
Yeah, it was as I started to provide the trigger, the initial trigger, which in my case was exposure to a pesticide. And at that
Hmm.
point, I lost them. I lost the clinician because maybe they'd
Hmm.
never heard of it. But we know, because we've looked at the literature, that exposure to pesticide, among many other things, is often a trigger for developing
Yeah,
chronic sensitivity to chemicals.
yeah,
And
yeah.
this because it's not in the medical training, right? So there, if it's not in
No.
the medical training, then there's no consensus.
I know my experience of my primary health organization in New Zealand may be very different from yours. And so each person, I know what's happening in the NHS. I know that in the US, you can probably, if you have the right kind of insurance, find someone who will help you. I don't know. I'm
Yeah.
imagining that. But I guess the point is within each of our systems, figuring out the best way to operate is often challenging as well. It's interesting, when I got my last new GP, I went and quizzed him, but I could do that. I could do that because I knew if I didn't want him, there was someone else in the practice that would take me. It was a test. If that is ever within the capacity of the listeners to achieve, that's an important thing to do.
In this country, there's two environmental health clinics, right?
Yeah.
And it's very hard to get into them. And a lot of people don't have doctors, so a lot of people rely
Mhm.
on walk-in clinics. In many
Mm.
countries, the cost to see doctors is prohibitive. And then if we're relying on doctors who aren't familiar, and again, they don't have the consensus, then we are often dismissed. I want to turn, if we could, to talk a little bit
Sure.
about, because of this challenge to find doctors and get in to see doctors, and even when we're there, we're often dismissed. A lot of us are self-diagnosing. And I
Yeah.
should just briefly say, and I'll share in the show notes, there is a self-diagnosing questionnaire
Yeah.
that comes out of the University of San Antonio in Texas. It's called QEASY, the Quick Environmental Exposure and Sensitivity Inventory. A lot of us are using that, and we're also connecting with community on the internet. And it's through dialogue with others, right, that we're learning about, yeah, I have this. I didn't know it,
Yeah.
but I have this. Would you say?
Yeah. So I think this is fascinating. And can I just reassure your listeners that the examples I'm going to use are going to sound trivial, but please don't think I'm trivializing your condition. It's just an easy example that's come to my mind spontaneously. How about gluten intolerance? You can decide that without anyone telling you that. and then you can adjust what you eat. It's interesting that in the gluten intolerance community, there has been a bit of tension around people who just declare themselves gluten intolerant and people who've been properly diagnosed. So there's also an exclusivity around, are you really gluten intolerant? If you're not getting medical recognition, and if you're trying to figure out whether there is something polluting your environment that's making you feel ill, do you need a diagnosis? And I think you're probably going to say, yes, it has to be a diagnosis because I need to join this community and learn from them. But by the same token, a self-diagnosis tool, I could see it imprisoning you as well, and focusing on how do I make my pain go away rather than how do I make the air freshener go away. And so if people are
Hmm.
saying doctors aren't helping me, then is the word
Hmm.
diagnosis necessary here? We know what the problem is. It's real.
Right. And part of the work that we do in community is finding out what laundry detergent or what can I use or what can I wash my
Mm,
floors with. But the diagnosis is very important because it gives us permission to be ill, and it
yes,
also allows us to get really critical accommodations at school and work, housing support if possible. Often those accommodations aren't available, but without the diagnosis, we're really at a severe disadvantage. And as a
sure.
result, many people end up without homes and without work, right? And so
Mhm.
you talk about the power of narratives, right? We, as people with illness, we bring our lived experience in these narratives to the encounter with the doctor.
Yep.
And the doctor has her or his own narratives, which are
Yep.
informed by different forces, and they conflict,
Sure.
don't they? They clash, don't they? So the medical diagnosis negates us often and
Yeah.
has more power.
I'm a sociologist, so I see everything in terms of power and who's got it and who doesn't. And of course, you have a brilliant, powerful sociologist from Canada, now in Toronto, I think, Arthur Frank. He's done some very powerful work on how medicine takes your narrative away from you. And he knows this firsthand because he writes about his own disease. He's had, upon his first diagnosis with cancer, how he had a story that got wrested away. And there was a very old 1960s psychiatrist, I think, who talked about diagnosis always being a negotiation, because even if the doctor said, no, it's not this, it's that, and you didn't agree, well, you weren't going to be a good patient. You had to be able to understand and accept the diagnosis in order to be compliant, which is what is expected of the patient. But I think, can we link this to the self-diagnosis? How do we talk to our clinicians in such a way that they can absorb our needs and our experiences and bring them back into a medical narrative that can make sense to us? And that's depending both on us telling a story well and on the clinician being able to listen. And being able to listen also comes from the era in which they were trained, to the way they use power, the way they recognize power, because most people in medicine see themselves as altruistic rather than powerful, and they're powerful.
Yeah.
And like you
And,
said, they hold the key to all these allowances, which are vital for your
yes,
health.
they are. And without those keys, life can be very difficult. And I moderate my own language. So instead of saying I have multiple chemical sensitivity, which is an illness that most clinicians don't recognize, I opt to say I had a pesticide exposure. And as a result, I have X and Y symptom, hoping that's something they'll understand.
Let me describe my first meeting with the incredible Lisa Sanders. And I don't know if you folks know who Lisa Sanders is. She's currently running the long COVID clinic at Yale, but she, for decades, ran the Thinking Like a Doctor column in the New York Times. And she's written the book Every Patient Tells a Story. And she ran the show on Netflix called Diagnosis, where they crowdsource diagnoses for confusing medically unexplained syndromes. So Lisa, who is a beautiful, beautiful doctor, I can remember when I first met her, I was meeting her with another doctor, and I can remember preparing myself to talk to doctors. And I said, oh, it must be such a pain when people bring reams and reams of paper telling you what they think they have. And she said, oh my God, it's beautiful. It allows me to know who they are. So there are doctors like that, but not all of them are. So I'm
No.
not sure. I think maybe I put that in my back pocket, that thing, not knowing whether I'm going to have a threatened doctor or a regular doctor.
have there been other illnesses that were not understood and people had these conditions and were dismissed? And a few come to mind: Lyme disease, for example, and long COVID now. We hear about multiple sclerosis often as a condition and illness that was often dismissed and is now validated. Do you want to talk maybe about one or two briefly and perhaps give us some hope that one day MCS may be recognized by clinicians? We can't guarantee, but if there's a trajectory that we could maybe hope for.
Yeah, I think Lyme disease is an interesting one, and Robbie Aronowitz wrote this piece on the recognition of Lyme disease and the connection between the community group that had the awareness, and these were, I believe, rich white women from Connecticut, because that's where Lyme is, who had the language, went to cocktail parties with the doctors, these groups who could talk to each other. So it's already social stratification, right? That they could convince a group of doctors who could then convince the CDC and so on and so forth. So it was all about social status. But think about, and I'm thinking COVID has done us a service in one sense, because I believe that our ME fibromyalgia patients who are regularly dismissed, they're on the low end of the hierarchy of diagnoses. But COVID came along and said, this is not in their head. We got the same kind of syndrome.
Do you think, Annemarie, that the communications that people with unrecognized, so-called contested illnesses with doctors, is it changing our doctors speaking? Is there any hope that they will change their ways, become more receptive, or are we going to continue to face these problematic dynamics?
I think one of the really important tools is the number of doctors who have long COVID. And while long COVID is not the same thing as MCS, it is in that same classification of diseases which are not neatly circumscribed, which don't have crisp boundaries, which assemble a range of different symptom profiles. And there are doctors all over the world suffering in this way. Thank you, COVID, perhaps, for highlighting this. That's a gift in amongst the tragedy of the sort of expansive nature of this poorly understood condition. If I were being political, because I'm fairly agnostic, I'm a theoretical researcher, but I understand these horrible syndromes because I have them in my family. And if I were an activist, I would be looking to broaden my classification of what I'm talking about here. And what I'm talking about here is a collection of different kinds of syndromes, including our chronic fatigues, our long COVIDs, our multiple chemical sensitivities, and I'm sure there are many more that are rejected, misunderstood, rather than split. And I don't mean in diagnostic terms, I mean in political terms. And work with medicine, find the right people, and Lisa Sanders is one of them, to advocate for the understanding of the misunderstood.
Yeah, and we need allies among scholars like yourself, others, because we're not in the cocktail rooms and the dinner tables, because we cannot be. And oftentimes we can't even be at the rallies. So a lot of the activism happens on the internet.
That's great. And use your pen. The pen is mightier than the sword, of course. The important issues around health, illness, and disease is that we need to be working together. We have to recognize that these stratifications often pull us apart. There are a lot of good doctors out there, but I think preparing to see a doctor, crafting the narrative, is also a political action. And
let's consider where doctors are, their mindsets, the pressures, their training, and deliver the narrative in a way that will give us the best chance of being helped.
I think, Aaron, one of the really important things, and your listeners are probably really aware of this, but even someone who doesn't have a complex condition should spend some time before they go in the room talking through the point that they need to make. But we all benefit best by making sure our stories land the way we intend them to. And it's a hard thing to do, but trying to put the anxiety aside and think, I'm talking to this person, what kind of information will help them to attend to the problem that I'm presenting today? And
May I ask briefly, you mentioned the word anxiety, and the moment I've ever mentioned anxiety to a doctor, well, you can see the light bulb going,
That's right.
Okay,
That's
It's a
right.
psychological condition. And one of the
Absolutely.
challenges with MCS is because we often have anxiety, but it's a chicken and the egg thing, right? It's not a
Mhm.
mental illness first. If I
Yeah.
breathe a certain product, I may feel anxious. It doesn't mean
Yeah.
I have an anxiety disorder. It's a
Yeah.
chemical reaction that's causing anxiety. But in the doctor's view, oh, anxiety,
Yeah.
and we know where that leads to.
We know where these red flags are. It is best to focus on the physical when that's the case. And it may be that some anxiety management is not actually solving the problem. Are there circumstances under which it is okay to be treated for the presenting problem, which might be psychological, but we know it's not a psychological disease?
But it presents as that, and we feel it, and we can experience that. Doesn't mean that's the root of the problem, though. It's much
That's
more
right.
complicated than that. And it's possible someone may have anxiety and MCS together, right? But there are also others who will say no because prescription medication will add to the body burden
Add to the body of
of chem.
chemicals that you're ingesting. That's right.
Well, Annemarie, thank you so much. It's been
Yeah,
really, really
it's been.
helpful.
Thank you.